Hello, I'm Peter Pronovost. I'm delighted to be here with my team. Healthcare harms too often, it costs too much, and it learns and improves too slowly. Still, 1 in 4 hospitalized patients are harmed. Over 50% of clinicians are burnt out, and over 50% of health systems have negative margins. And despite spending heavily on tech, we still have negative labor productivity. It doesn't need to be this way, though. Healthcare is riddled with defects in value, and health systems are working to make them visible and design them out. And I hope CMMI focuses on making defects in value removed and specifically on improving productivity, because we just keep asking our clinicians to do more and more, and it's burdensome for them and unsafe for patients. One of the ways that we could help working to improve our productivity is getting rid of wasteful policies. We started this thinking most of the wasteful policies were going to come from CMS. It turns out most of them were our own self-imposed policies that we've gotten rid of, but there's a lot that we can still do together. And we applaud CMS and Jonathan Blum and his leadership for pulling this conference together. We're honored to participate, happy to share our work, and hopeful that together we can continue to work on material reductions and burdens, which will help improve the lives of our patients, our clinicians, and the financial performance of our organization. So I'll turn it over to Michelle Herford, our CNE.
Thank you, Peter. And thank you all. As we begin this discussion, I think it's important to first and foremost remind everyone that the very rewarding and impactful profession of nursing continues to remain the most ethical. And our commitment to ensuring that we deliver the safest, highest quality care 365 days a year is unwavering. Despite those rewards, it comes with a significant amount of stress. And as noted on this slide, it's a very busy slide. It starts with a very busy 12-hour shift, which includes developing a plan of care and implementing appropriate interventions to ensure our patients are healed at the best possible times. Those interventions, by the way, include medication administration, pain control, coordinating care with others, and quickly intervening when a patient decompensates acutely. It's also important to note a significant portion of our day is spent in documentation. Documentation in order to communicate with other caregivers, but also to ensure that we are compliant with numerous government and hospital policies. The burden of meeting this frustrating action leaves very, very little time for us to provide direct patient care. It's not only frustrating to the nurse, it's also frustrating to the patient. And this further leads to mental exhaustion and burnout, especially when we know we cannot deliver our best. Next slide, please. So we also know that there's a myriad of laws and regulations, as well as many accreditation and other professional standards, which are created and intended to support our healthcare system. However, we also know that despite the fact these areas may overlap, oversight bodies at times operate without coordination. This contributes further to the growing concerns about the burden of administrative requirements on clinicians. And often, we're finding that policymakers fail to assess the impact of these new regulations or requirements before they are implemented. And by the way, this includes our own healthcare organization policymakers. So what must happen? These entities must engage clinicians and patients in the process in order to identify and eliminate healthcare laws, regulations, policies, standards, and administrative processes that contribute very little value or no value at all to patient care. So I'll now turn this over to Jen Gonzalez.
Thanks, Michelle. So I'm extremely proud to share what we have accomplished within our nursing governance councils at university hospitals. These councils are a forum where frontline nurses come together monthly and discuss professional issues, monitor patient quality, they innovate, and especially bring forward concerns with their work environment. It is within this structure that we had a brainstorming session to really understand deeper the burdens that nurses are facing on a daily basis. So we simply asked the nurses, what policies do we have in place that are burdensome or that don't bring value to the patient or your work? What processes are burdensome, and even what technologies? So you can imagine that we were able to collect a very long list, and we are consistently adding to it. So although we are only presenting a few of these burdens today, when adding up all the time reported by the nurses caused by these burdens, it translated to over half of their working day. We knew we had to take further action and understand the source of all of this burden to decrease it. So one specific burden that we delved into was the frequency of taking vital signs. The concern here is that we had standardized physician orders of frequencies for vital signs to be completed on every patient. So depending on the location of the patient, the orders were for every hour, every 2 hours, every 4 hours, or every 8 hours. And there was no room for variation or adjusting for the patient's clinical picture. So we thought that maybe we are a little overzealous with this practice. And have we even considered how disruptive this could be for our patients? We wake people up in the middle of the night to take vital signs because there are standing orders. It's a task, not because the patient has a clinical indication for this. So this type of standardization that we've created contributes to the cognitive workload burden and workload that's commonly reported. So here's how we tackled this. We reviewed evidence-based literature. We did process mapping. We reviewed regulatory standards and looked to our peers and found that they also have similar practices. We analyzed the 4,000 CMS publicly reported citations at cms.gov and found 6 deficiencies related to compliance to hospital policy surrounding frequency of vital signs. We identified that we had 13 internal policies that reference vital signs. We also analyzed 2,700 provider orders to identify where these frequencies resided. And we also found that these orders stayed consistent through the entire hospital stay. And that is extremely important in this modern day where we are holding patients because they can't get placed, but they've been medically stable for days. So making a bold move, we removed the frequencies from 300 of those orders, and we replaced with a procedure for standard of care, which allows for minimum frequencies and gives autonomy for nurses to take more vital signs if needed, if the patient's condition warrants it. We monitored this change over a 4-week post-implementation period, and we were able to meet the daily minimum vital signs documentation for our entire health system. And there were no reports of patient harm that contributed to this change. So we believe that this intervention has eliminated over half of those frequencies that were formerly in place. And to give you some perspective on what this means for our front line, this is a minimum return of 130,000 hours annually that can be reallocated to our patients in meaningful ways. So I'll now go ahead and turn it over to Kalia to share more of our work surrounding the plan of care and governance.
Thank you, Jen, for setting me up nicely and sharing the work that we have done. On the next slide, I'll just talk a little bit more about how we started Jen already shared how we started down that path of looking internally at burden within our organization through asking nurses. One of the things that came out of that work was that nurses identified the care plan as an issue as it relates to documentation, taking up time from nursing care, from patient care. Nurses estimated that they spent at least 10 minutes per patient documenting a plan of care that they felt was disconnected from the full interdisciplinary care plan overall. We acknowledge the conditions of participation and regulatory standards that require nursing staff to develop and maintain a plan of care for each patient, and that it be reflective of the findings of a complete nursing assessment as well as input from other disciplines as appropriate. The regulation or the standards also require that this can be a part of an interdisciplinary plan of care. As we continue to examine the issues, we determined that care plan documentation burden is layered. It can be layered by additional care plan documentation requirements that exist within accreditation organization standards for specific conditions such as pain or restraints, or maybe even falls, as our policy requires in our organization. We further looked at the interpretive guidelines and recognized that the standards for care plans are examined under the nursing services chapter. We want to be clear that we agree that there is a need for patients to have an interdisciplinary plan of care, while recognizing that in its current state, silos and workarounds are being created really to meet regulatory and internal policy requirements, and that the intention for the care plan standards are not being met. On the next slide, we propose some solutions that can help with the documentation burden as it relates to nursing care plans. So to enhance value and eliminate burden, we believe that new approaches are needed. And so we're happy to be able to be here and share what we think could be a new approach to consider. We had the fortune of being able to speak with the Office of Burden Reduction a year ago about the idea that perhaps we can prompt EMR vendors to design functional, interactive, interdisciplinary plans of care templates, because many hospitals have already developed plans of care templates, whether they call it a physician handoff tool or some other document. It may already exist that is pulling in interdisciplinary information such as labs, medications ordered, medications administered, many of the things that you need to know, point of care testing. And those are being used in a way that you would anticipate a plan of care to be used. But we want to optimize these tools to be more reflective of the interdisciplinary team. And that's just one example of how we may be able to advance this issue and reduce some of the burden of a care plan that seems siloed. We also believe that collaborating with accreditation organizations to examine standards that require plans of care for specific conditions occur. We mentioned that there is the standards in the CMS conditions of participation for nursing to develop and maintain a plan of care for patients, and that it should be interdisciplinary. But then when you layer on that if you are a patient that's restrained, or if you do have pain, according to your accreditation organization, you may also be required to develop a plan of care. And again, it's getting further and further into the margin where it's only nursing focusing on that and not so much the interdisciplinary team. And then we recommend or would suggest considering updating the standards to require the creation of the interdisciplinary care plans with the interpretive guidelines instructing surveyors to review the key contributions of the interdisciplinary team. So again, it advances us out of the silo that the care plan is just for nursing, when really we're trying to make sure this is interdisciplinary for the patient. So on the next slide, we move out of just nursing when Dr. Pronovost reached out asking us to start to think about this, start to think about this framework of stopping what we're doing, automating what can we automate, what can we outsource, and what should we protect as a practice or as work. The examples continue to roll in from many, many disciplines, not just acute care nursing. And the proposed solutions started to roll in. So I'm happy to note that much of what was discussed earlier in terms of prior authorization and things like that, that will continue to be looked at. Many of those were the same examples that others in our organization brought forward as issues. Yet another burden that we identified, or should I say, with the help of CMS through our regulatory and accreditation organization, they helped us identify that we had a gap as it relates to the beneficiary notice initiative, specifically the important message from Medicare and the Medicare outpatient observation notices. For those that may not be familiar, the important message from Medicare or IM notice informs hospitalized inpatient or Medicare beneficiaries of their hospital discharge appeal rights. And the MOON or Medicare outpatient observation notice informs beneficiaries that they are outpatients receiving observation services and they're not inpatients of a hospital or a critical access hospital. We understand that this was a congressional act. We understand its significance. Of note, however, currently each notice requires a wet signature from a patient or a family member. And that's where the burden continues to be. This was further realized during the COVID-19 pandemic when physical distancing was necessary. So on the next slide, we propose some suggestions that we've learned from our internal teams about how we might reduce some of this burden as it relates to this important beneficiary notice initiative. So to enhance value and eliminate burden, our care transitions team and utilization management teams recommend reevaluating the wet signature requirement to align with the technological advances, including iPad signatures and telephonic and electronic attestations as one such example. And then again, reviewing existing accreditation standards as it relates to patient rights and how we could incorporate these standards or incorporate these notices into the rights already provided to hospitalized patients. So I have explained some of the work that we have done internally, as well as how we've looked at what we think might be external opportunities to collaborate and improve in the care that we provide and reduce burden. I'll turn it over to Dr. Pronovost to share the call to action.
Great, thank you. And if I could have the next slide, please. So, what you heard is the compelling need for reducing burdens, how 50% or more of a nurse's time is spent in the burdens. And much of it is imposed by us on health system. And we're delighted to share the systematic efforts we are working at to say, what can we stop doing? Because it makes no sense. And that's likely revising policies. What could we automate through technology? What could we outsource? And what stays sacred with the nurses? But we would ask CMSs to continue this dialogue, and we'd be happy to work with you to explore how together we can clarify some of these policies and work together to reduce the burden. As I said, much of it is imposed by us, but some of it is from CMS, some of it is from the accreditation organization, and much of it is ambiguity in the regulations that our lawyers are conservative. So when there's ambiguity, we edge to the side of conservative. And if that ambiguity were clarified, I think it would do a lot to allow us to reduce the burdens. So for our colleagues at UH, we applaud CMS and look forward to collaborate with you on this very important effort.
Well, thank you very much. As I stated in the prior panel, it is important that we all collaborate. And we're also live, so sometimes things go faster than we anticipate. And I would be remiss if I did not take the time to really let you know who you just heard from with the great work that the university hospitals health system is doing. So you heard from Kalia Fisher-Grace, who's a registered nurse and serves as the System Director of Policy for the University Hospitals Health System. She has blended her clinical experiences with systematic approaches to attain high-quality patient outcomes and has led transdisciplinary teams to develop processes that will improve safety and quality for patients at the individual hospital and health system level. Additionally, you heard from Jennifer Gonzalez. She's a board-certified clinical nurse specialist at University Hospitals Cleveland Medical Center. She has a combined 20 years of healthcare, clinical, and leadership experience. She's responsible for nurse innovation with focused efforts on improving the work environment for clinicians and patient safety. Michelle Hereford is the Senior Vice President and Chief Nursing Executive at University Hospital. She has the responsibility for the overall delivery and management of nursing operations, professional practice, education, professional development, research, administration, and clinical services. Additionally, she is charged with staff accountability for enhancing a clinical practice environment that is patient-centered with unsurpassed patient experience, clinical quality, and patient safety. Dr. Peter Pronovost is the Chief Quality and Clinical Transformation Officer for the University Hospitals Cleveland Medical Center. He is the patient safety champion, physician executive, critical care physician, and researcher with more than 1,000 peer-reviewed publications. He was named one of the 100 most influential people in the world by Time magazine in 2008. And also that year, he received a MacArthur Foundation Genius Grant. While serving as Chief Clinical Transformation Officer at University Hospitals Health System in Cleveland, and as a professor in the Schools of Medicine, Nursing and Management at Case Western Reserve University, Dr. Pronovost developed a checklist to make visible defects in value and deployed a management and accountability system to eliminate said defects. This system reduced the annual cost of care for Medicare patients by 30% over 3 years while improving quality. In 2022, Dr. Pronovost led the efforts that culminated in the University Hospitals winning the American Hospital Association's Quest for Quality Award, the industry's most prestigious honor recognizing its member organizations for their commitment to quality. He was also named the Veal Distinguished Chair in Leadership and Clinical Transformation in 2023. So once again, I'd really like to thank everyone from the University Hospitals for taking the time to speak with us today and for the great presentation. We will be taking a 5-minute break, but before you go, we would love to hear your input from all of the attendees on a question. We have a wide variety of stakeholders with us today. We have patients, clinicians, providers, plans, clearinghouses, EHR vendors, and more. So when you registered, you gave us that information. So there's over 2,400, 2,500 of you, might be more right now. But from whatever perspective you're attending today, would you please visit the Attendee Hub, open the discussion board labeled Burdens and Challenges, and let us know what comes to mind when you think of the most burdensome challenge that you face currently in healthcare. Thank you so much. We appreciate your insight, your feedback, and your time, and we will see you back here shortly.